Cystic neoplasm of pancreas. So first let's take a look at the WHO classification of your cystic neoplasm. It consists of your serous cystic neoplasm, which is further subclassified into serous cyst adenoma, which could be a microcyst adenoma or your oligocystic microadenoma. Then we have your serous cyst adenocarcinoma. Then mucinous neoplasm, which consists of your low or intermediate grade dysplasia, a high grade dysplasia, and it may be associated with your invasive carcinoma. And then we have your intraductal papillary mucinous neoplasm, which may be associated with your low or intermediate grade dysplasia, high grade dysplasia, or it may be associated with your invasive carcinoma. Now, we will study the various neoplasms in a tabular form, as you need to differentiate the various sort of cystic neoplasm. The most important point to be remembered in the cystic neoplasm is your fluid characteristics. So, the first neoplasm that we shall discuss is your serous cyst neoplasm. It occurs in the mean age 61 to 65 years, having a more female dominance. The gross features include they are microcystic, of variable size, have a stellate scar. They have a clear cytoplasm, have uniform nuclei and glycogen rich cell. So, these are your clinching features pointing towards your serous cyst neoplasm when you look at the gross features. On imaging, you would find it to be microcystic and it has the characteristics which is your honeycomb pattern. And the cystic fluid features include your low viscosity, low CEA, low amylase, presence of cuboidal cells and glycogen rich cytoplasm, right. So, these are your most important points with respect to your cystic neoplasm, serous cystic neoplasm. Now, moving down to the next cyst is your mucinous cyst. So, the mean age group is between 45 to 55 years, has a female is to male ratio of 10:1. Then the gross features include it is large size, it is multilocular, thick walled, tall columnar mucin is present, and it has your ovarian type of stroma, right. And your imaging features would be the cysts are macrocystic, have peripheral calcifications, and there is no communication with the duct. Now, in contrast to the serous cyst neoplasm, which was microcystic and it had a honeycomb pattern. Now, the main differences between your cystic fluid of your serous cyst and your mucinous cyst neoplasm include it has high viscosity, high CEA, in contrast to your serous cystic neoplasm, which had a low viscosity and a low CA, and it also has low amylase level. They have columnar cells, and an important point is that cystic fluid over here shows your KRAS mutation. Then the next cystic neoplasm is your intraductal papillary mucinous neoplasm. The age commonly presenting is your 65 to 75 years, has a equal female is to male ratio. Now, even they could be of variable size, are multilocular. The important feature over here is that it involves your main duct, right, and they have mucin producing epithelium with papillae. The imaging features include your macrocystic and ductal involvement. So, this is your clinching difference between your intraductal papillary mucinous neoplasm and your mucinous neoplasm, and the features include high viscosity, high CEA and high amylase level. So, these are your some of the important points with respect to your cystic neoplasm. So, please do remember the differences and specifically your cystic fluid differences. Now, just to summarize your cystic fluid differences. So, if you do a cystic fluid analysis and there is a low viscosity and low CA, then we check the amylase level. Now, if this amylase level is high, then it would be a pseudocyst. We have discussed the pseudocyst part in your acute pancreatitis part 2 video, and if the amylase is low, then it would be your serous cyst neoplasm. Now, if the cystic fluid is having your high viscosity and your high CEA, then we check the amylase level. Now, if this amylase level is low, then it would be your mucinous neoplasm, and if this is high, it would be your intraductal papillary mucinous neoplasm. Now, regarding the management, so I have taken this table from your Bayesian law, which has beautifully explained your cystic neoplasm management. So, if we see a cystic neoplasm, we investigate with MRCP or EVIS plus fine needle aspiration cytology. We send the fluid for CEA and cytology. Please remember that CEA more than 192 indicates your mucinous neoplasm. Now, if it is a intrapapillary duct mucinous neoplasm or a mucinous neoplasm, then we check for the absolute indications for the surgery. The absolute indications for surgery include your carcinoma or a high grade dysplasia, then we have your solid mass, a jaundice enhancing mural nodules the size of being more than 5 mm, and your main pancreatic duct dilated more than 10 mm. Now, then we check for your relative indications for surgery, which has your growth rate more than 5 mm per year, serum CA99 more than 37 units per liter, your main pancreatic duct dilated between 5 to 9 mm, your cystic diameter more than 40 mm, a new onset of diabetes mellitus, acute pancreatitis, and enhancing mural nodule. So, these are your relative indications for surgery. So, if the criteria meets the absolute indications for surgery, we proceed towards surgery, whereas if there are relative indications for surgery, then we check for the acceptable surgical risk with 1 or 2 indications or high surgical risk but more than 2 indications, then we go for surgery. Right. So, if there is an acceptable surgical risk, even with a 1 or 2 conditions, we can go for surgery, but a high surgical risk, but there are more than 2 indications, then also we need to go for surgery. Now, if there is a high surgical risk with 1 indication, then we monitor 6 monthly with clinical evaluation, serum CA19 level, and MRCP and endoscopic ultrasound. Right. Now, so if it is a solid pseudo papillary neoplasm, we consider a surgery. In case of a cystic neuroendocrine tumor, we again perform a surgery, and if it is a serous cystic neoplasm or other benign cyst, then we can manage it conservatively, right? And if the patient is unfit for surgery or no indication for surgery, we monitor at 6 to 12 months and then annually with your clinical evaluation, serum CA19 level, and MRCP and endoscopic ultrasound. Right. So, this is all about your cystic neoplasm of pancreas. So, please do remember the fluid characteristics in your this section, which is your most important point and the most frequently asked questions in your exam.